Thank you for joining us for the third session of the 2021 ISPD Virtual Education Series. My name is Neetha Vora, and I will be moderating today's webinar, which is focused on lower urinary tract obstruction. We will first hear from Dr. Louise Wilkins-Haug, followed by Dr. Rodrigo Ruano. But before we get started, I have a few housekeeping items to share. If you need technical assistance, please use the chat function. Throughout the presentation, you can submit questions for the presenters in the Q&A function. You can use the thumbs up button to vote for the questions you like the most, which pushes them higher up the question list. You can choose to raise your hand to ask a question, and I may call on you if I'm able to. The event is being recorded, so if you do not wish to be recorded, do not raise your hand to speak or submit a question to the Q&A. And I will now introduce our first speaker for today, Dr. Louise Wilkins-Haug, who is the Division Director of Maternal Fetal Medicine and the Director of Reproductive Genetics at Brigham and Women's Hospital, Harvard in Boston, Massachusetts. Thank you, Louise.
Great. Thank you very much, Nita, for the introduction. So I'm very much looking forward to doing this today because I think this is a nice way to present this as far as what is the etiology behind what we're seeing on the ultrasound, what are the mimics, and then I'll turn it over to Rodrigo to talk about interventions because it's not just all a large cystic filled area and always posterior urethral valves. So I have no disclosures. So I was going to put this around a case. This is Mrs. Smith, fourth baby. She comes to your office with her 11-week ultrasound report. And you're wanting to see a nice nuchal translucency greater than 2, which you do see. But what they also say is that she doesn't have a bladder that looks like this, but she has a very large megacystis that looks something like this. And the longitudinal diameter on this bladder is 9 millimeters. And I think certainly you can see on these images here, it's, even at 11 weeks, quite distinctive when the bladder is this full. What does she want to know? She wants to know, is this going to go away? She's now sitting in your office with this report. What else should I be worried about? Is this going to impact the child's life? What's this going to mean? How can we sort this out? Could this be genetic? Do I need testing? And lastly, can I fix it right now, or does it get fixed after delivery? And I can tell you from the time of walking over from her ultrasound to your obstetric office, she probably has already Googled this, and she probably wants to jump to the fourth question right now. Can we do something before the baby's born? But I want to go through with you the other 3 questions because those are as, if not more important, to really sort this out before we get to Rodrigo and his talk about what do we do. So megacystis, the full bladder on this first trimester ultrasound, is really a large descriptive term, and it can involve isolated megacystis, and actual posterior urethral valve is only a small portion of this. And so I think that's very important to remember that every large bladder is not necessarily a posterior urethral valve, and it really takes some work to sort through this. So some definitions that are used when it's in the first trimester, there is a longitudinal bladder diameter that's obtained. And if it's greater than 7 millimeters, then that's considered to be large. I think one ballpark to remember is, it shouldn't be as big as the gestational weeks. And as you saw in those first images, it clearly is visible when it is that large. And it is one of those items on a first trimester 14-week scan that is expected to be detected. So certainly something to note on an ultrasound report if you do see it. So here's what about 9 millimeters would look like, and then much larger at 13 millimeters. So you can see it's quite a distinctive image, even in the first trimester. And again, thinking that, once you get beyond the gestational age of weeks in your measurements, you're way too big. Now, megacystis in the second trimester has a little bit of a different diagnosis and different definition for the word. So it's really after 18 weeks, the bladder is enlarged and it doesn't empty over 40 minutes of visualizing the fetus on ultrasound. and you often can see a keyhole. So this then is a large bladder, and you can see the distinctive keyhole appearance here, where the bladder is, and the urethra is dilating some, maybe down to a posterior urethral valve, but not always. Keyhole is not always synonymous with posterior urethral valve. And then distinctly in the second trimester, within the definition of megacystis, is the fact that there's oligohydramnios often, and that you start to get changes, as you can see here, in the structure and the parenchyma of the kidneys themselves. So she wants to know, is this going to go away? So between 7 and 12 millimeters, remember, not bigger than the gestational age, actually a fair number of these actually resolve. And in some recent work done by Fontanella, many of them resolve as long as the karyotype is normal and it's not further enlarging. So if it's not bigger than the gestational age, then it is reasonable to think that it might resolve. However, once it gets beyond 15 millimeters, there's this, this threshold which it crosses quickly and then goes into the area where it's unlikely to resolve. And then, commonly, as they were originally seen in the second trimester, those megacysti are unlikely to resolve. So it's really only the smaller ones that are less than the gestational age of the fetus that you can have some hope that it may resolve, as long as the karyotype is normal, and that's important. She wants to know, could this be a sign of other concerns? What do I need to do to figure this out? So the most common cause of a large bladder, but not the only cause, but the most common cause, is lower urinary tract obstruction, or LUTO. And of this, then there can be posterior urethral valves, there can be urethral stenosis, and urethral atresia. So just kind of keep that thought in mind, that not all megacystis is actually lower tract obstruction, and not all lower tract obstruction is actually posterior urethral valve. So it really takes some sorting out before going to any type of intervention. It can be a sign of karyotype abnormalities. So certainly associated with all of the different karyotype abnormalities, as I'll show you. What to do, maybe to get a CPS done. You can get fluid from the bladder, or if it's a second trimester and there's still fluid present, you can do an amniocentesis. Also can be associated, though, with a spectrum of malformations that are anal rectal. These are the ones that are most difficult to rule out. And then it can also be associated with other structural malformations. So the large bladder itself as a part of a genetic syndrome, or other developmental malformations in structures such as the heart. These can also be difficult to rule out because only some of these are going to be identified by ultrasound, and only some are going to be identified by ultrasound, and not all will be identified by genetic testing. So think in the realm of a large bladder, it may be obstructive, but it also may be due to an underlying connective tissue disorder. So just to give you a sense, though, of how these different categories relate to the essentially the megacystis that you'll see. This is a recent study that looked at just over 500 pregnancies, pretty much split between early and late megacystis, using the definitions that we just talked about. They had outcomes on 3/4 of them, and these were shunted if they were male and had oligo. But I think I'll leave that discussion to Rodrigo to go through, but I think stepping back and looking at the workup that these almost 500 cases got is very informative, because I think, as you can see here, LUTO, the lower urinary tract obstruction, does account for half of them. Okay, so that's your biggest category. But a third are going to be other anomalies, including genetic syndromes. And then this is your group here that, even with a fairly large bladder, may go on to have a normal outcome, or just an isolated urologic condition. So thinking about LUTO, remembering it's posterior urethral valves, but it's also urethral atresia and urethral stenosis. So while that is the largest group, not all of LUTO is actually How about that third, though, that are due to genetic syndromes or other anomalies? Certainly, as you look through the numbers here, a fair portion had aneuploidy. I think to keep in mind that it's not only autosomal aneuploidy like Down syndrome. We've seen megacystis with sex chromosome anomalies, and it's also been reported with 22q. So this gets to a growing philosophy among MFM geneticists and others in this area that we really don't know what the presentation is of some of these genetic conditions in the fetus, and it's often very different than how they present in the child. So certainly doing genetic studies is well worthwhile in these cases. Then the other conditions that I mentioned, which are harder to exclude, are these anorectal malformations, the multiple congenital anomalies, and this is an interesting overgrowth syndrome category here, which I think many people don't think about when they see these large bladders. So in counseling patients, though, for this group here, we have CVS, we have vesicocentesis, we have amnio to get an answer for these. I think what's difficult for patients to understand and appreciate is that these, 2/3 of these genetic and anomaly groups aren't going to be discernible in the first trimester. So it's going to take some time to sort out whether or not there are other associated genetic syndromes aside from aneuploidy, or whether there are other structural malformations. And does it matter if these were first trimester megacystis or second trimester megacystis as far as the anomalies and the genetic syndromes? There is a tendency that if there is earlier detection of the megacystis in the first trimester, that those tend to be more associated with the structural anomalies and the overgrowth syndromes and the genetic syndromes. So again, the ones that are first trimester, your concern is going to be a bit higher that there's something else going on, and we may not be able to discern it completely without further genetic studies beyond aneuploidy detection or further ultrasound in the second trimester. So we have CVS and vesicocentesis to get to our aneuploidy answer. Trying to get to the ANMs, the malformations that are localized in that region, the urethral and anal atresias. These can be the early megacystis, they can be the very distended bladders, but trying to get ultrasound to detect the absence of the perineal muscular complex really can't happen until after 23 weeks. So again, we can't really close that door on whether there's an associated anal atresia or urethral atresia creating this megacystis until later in the pregnancy. Genetic syndromes, there's other possible genetic testing that can be done, and then certainly multiple congenital anomalies. Some of these are going to be associated with increased nuchal translucency, and some of these are going to be seen on an early survey, omphalocele, cardiac anomaly, but some of them won't be seen until the third trimester. So a rare cause of this can be microcolon megacystis, and certainly that often is not detected until later in the third trimester by some classic bladder and then bowel signs. So what does this mean for Mrs. Smith? What does she have, and how can we put this together for her? So she has a moderately large megacystis. It's in the first trimester. It may still resolve. Can't take that away completely from her. She does have a higher likelihood that there may be other anomalies there, whether it's aneuploidy or genetic syndrome or structural anomalies, because it was detected in the first trimester, has a normal nuchal translucency, but that doesn't protect her completely. So we would recommend genetic testing. You can have either one of these three done. Certainly we would get a microarray done. But one needs to also think about those overgrowth syndromes that have been associated, Beckwith-Wiedemann, Soto syndrome, whether to go further than just your chromosome microarray and order specialized methylation studies for Beckwith, or some of the overgrowth gene panels should maybe be considered. And then I put this up, this is more in the research realm. There are specific genes and gene panels that are associated with megacystic microcolon. but I don't think that is something that's standardly offered, and certainly is much more uncommon than some of the overgrowth syndromes, which maybe should be. So she and her partner return at 16. They went ahead and did a CVS. They had a normal chromosome microarray. They elected to do just Beckwith studies. Those were negative. And her fetal survey is normal, including normal cardiac images and normal amniotic fluid. And she wants to know, should she get an MRI for esophageal atresia? You know, that's one of the structural anomalies that we often can't see early, or can an MRI help determine the presence of any other structural anomalies that may be just beyond the resolution of what we're seeing with ultrasound? There's not a clear answer to this, and I think certainly working with your team that you have, it's one question to bring to them. So her partner and herself not only reached out to friends and family, but she did a deeper dive on Google, and she wants to know, shouldn't she consider fetal therapy? So where do they stand at 16 weeks? Have we been able to really pinpoint it down to something that fetal therapy is going to be of benefit to her for? So remember, like the common categories were normal, LUTO with its categories within that, and then complex megacystis. Well, you know, I think we're beyond the normal going to resolve stage. It's still present. We've tried to address the complex anomalies as best as possible with a detailed survey at 16 weeks, as well as a normal microarray and normal Beckwith study. And that really leaves LUTO. Within LUTO, though, in about equal distributions are going to be urethral atresia, posterior urethral valve, and urethral stenosis. And it's difficult to sort these out. And I'm going to leave all of that to Rodrigo, because I know that that's going to be an interesting talk. So she's left probably with about a 15% chance that there is something structural that we haven't been able to detect. We're at 16 weeks. That's you can get a survey, but it may not be complete, or there may be things that aren't seen or aren't present until third trimester. So it's about a 13% chance that she still may have something else going on besides a clear-cut lower obstruction tract anomaly. So one other kind of tip that sometimes is used to try to differentiate between those LUTOs is whether or not there's an umbilical cord cyst. And there's some discussion that may help differentiate between posterior urethral valve and urethral atresia. I would love to hear Rodrigo's comments on this. Keyhole on ultrasound, as I said earlier, can be within either of these. If there is an umbilical cyst here, as I showed in a picture here of an infant after delivery, and then in the ultrasound images with Doppler there's a much higher chance that it's urethral atresia than a posterior urethral valve. Why would this be? Well, if you think back to embryology, there is a connection that then becomes the urachus, the allantois that connects the bladder to the umbilical cord. And that is still open up between 6 to 12 weeks. You've got severe bladder enlargement. That may prevent the allantoic closure, and that will lead to a cystic dilation or of the umbilical cord, or closer to the cord insertion site itself. So it's a reflection then of the increased bladder pressure that then back diverts into what becomes the urachus. So I think a little tip just to kind of keep that in mind is if you can look for that, at least if you're trying to sort out whether or not this first trimester megacystis is the urethral atresia or a posterior urethral valve. There are some algorithms to kind of put all this together, relying on the nuchal translucency, which was normal in her case. The diameter of the bladder was not greater than 12 in her case, and there was no evidence of an umbilical cord cyst to push us to atresia. So she would be falling more towards this looks like a posterior urethral valve, but she still hasn't completely cleared whether structural anomalies are there. So she does get an 18-week ultrasound. She then has identified small ASD, VSD, some vertebral body anomalies. Now the stomach is thought to be small. She does get an MRI with esophageal atresia, and she probably has a diagnosis of Bacterl then with anal rectal malformation. So she undergoes conservative management. Her megacystis stays stable. She has normal amniotic fluid until she gets to low fluid at 30 weeks. But she delivers a newborn at 37 weeks that does have Bacterl and urethral stenosis, as well as the other identified structural anomaly. And just for the obstetricians among the group as well, she had normal fluid up until 30 weeks, at least from this large study that looked at the outcome of these children with obstruction who then develop oligohydramnios. As we know, when it happens early, that's going to impact their pulmonary development. As with from premature rupture membranes, happens before 24 weeks, significantly going to impact their chance of surviving. If it happens later in pregnancy, though, their chances of surviving their pulmonary disease are very good. So take-home points. If the large bladder is diagnosed between 11 and 14 weeks, it's really known as a megacystis. If it's less than the gestational age, just for ballparks, it may still resolve. If you have an NT that's greater than the 95th percentile, so you've got the large NT and the megacystis, you're at a much greater risk for a complex megacystic disorder with other anomalies. There are many mimics of what we think of just being isolated lower urinary tract obstruction. It can be to aneuploidy. It can be to developmental field malformation in the anal rectal area. And then it can also be due to a more global picture, such as genetic syndromes, some of the overgrowth syndromes that I mentioned earlier, some of the connective tissue disease syndromes, and as this patient had, also associated with a multi-field developmental syndromes with findings in the vertebra and in the heart and in a T fissure consistent with Bacterl. So, and then just a take-home point that the urinary atresia is more often associated with umbilical cord cyst. And I will leave this for Rodrigo to talk about the role of cystoscopy to see if we can try to filter down to more specifically posterior urethral valve and differentiate that from the stenosis or the atresia and really target the fetal therapy to the condition rather than fetal therapy for all of megacystis. Okay, I will send this over to Rodrigo though, and I'm very interested to hear what his current thoughts are and his current approaches and new innovative ideas are for addressing not only this whole area, but then the different subcategories where we have the potential to intervene.
Thank you, Dr. Wilkins-Haug, for that great talk. Please put your questions in the Q&A if you have any, and after Dr. Ruano's talk, we will have some time for questions. I will now introduce Dr. Ruano, who is a professor of OBGYN and reproductive sciences at the McGovern Medical School at UT Health Science Center, Houston, and the co-director of the Fetal Center Children's Memorial Herman Hospital in Houston, Texas. Dr. Ruano, we look forward to your talk.
Thank you, Nita, for the introduction. So thank you. First, I would like to thank the Society, International Society for Prenatal Diagnosis, for the invitation, which I think is one of the main societies that we have that can guide us in doing our job for the best for our patients. So it's a pleasure for me being here with you. And also, I would like to thank Dr. Wilkins-Haug for the wonderful presentation. And she gave lots of good concepts and definitions that will make my talk much, much easier. So thank you, Louise, for your great talk. So what I'm going to focus today here is on fetal interventions for LUTO, lower urinary tract obstruction, based on a prenatal stage system. And that's what I'm trying to see. The innovation that I'm bringing here is, of course, we're going to talk about fetal cystoscopy, but also a stage system that we can help us guide the best treatment that we can do prenatally. First, and then Dr. Wilkins-Haug said very well, spoke very well, and I love it, that she talked about cause of LUTO. So LUTO is a very complex, diverse situation that we see enlarged bladder. Usually we see keyhole sign, we have bladder thickness and bilateral hydronephrosis. So meaning that probably we are facing an obstruction inside the urethra of the fetus. So, but then we have different, a huge spectrum of diseases that can cause that same features that we are seeing in that fetus, in this fetus. So the first is the posterior urethral valves. That's the first cause of obstruction. And depending on the age of the baby, when I mean age of the baby, I mean also prenatally and postnatally, because if you see postnatally, 80%, if you see the data from postnatal series, you're going to see that 80% of them, the obstructions, 80% of them will be posterior urethral valves. But if you see in the first trimester, Louise said very well that we can have other causes of obstruction. And then we have urethral atresia, we have urethral stenosis, but we can have also rare diseases that, for example, Pruny-Belly syndrome. Pruny-Belly syndrome for me is something that is a specific disease that we don't know the cause, but we have an abdominal wall weakness, a bladder wall weakness, that the bladder will be very distended, the kidneys will be distended, hydronephrosis, hydroureters, but there is no actual an anatomic obstruction that is causing that dilated bladder. So if you see the amount of amniotic fluid in this situation will be normal. That's different that if we have Pruny-Belly features, that's a secondary finding after we have urethral valves or severe urethral atresia or a complete obstruction that distended the belly of the fetus and cause secondarily the Pruny-Belly that we are seeing. But we have also anterior urethral valves, very rare, megaurethra. We have prolapsed urethral seals that usually we see this situation more often in females. So when we are talking about LUTO, it's true that 80–90% of them, 90% or even more, we are talking about males, but we can have also female fetuses that can have similar situation caused by prolapsed urethral seals, for example, or even cloacogenesis. That's a very complex situation that Louise said very well, that we can have anorectum problems. So it's very important when we see LUTO, we also think about intestinal or bowel problems. But then the second problem, the second thing that I would like to discuss, the importance of studying this situation. If you see the postnatal data, of course, you're going to see that incidence is 1 in 10,000. So that's a rare disease. But if you consider our data, if in those cases if we have a complete obstruction before 24 weeks, she presented that slide to you, the data, before 24 weeks, we have a higher chance of mortality, higher than 80–90%, because we're going to have severe pulmonary hypoplasia. And among those 20 or 10 patients who will survive, more than 89% will have end-stage renal disease. So even this incidence is a little bit lower because the majority of babies will have termination pregnancy or will die in utero or will die just after birth before they go to the NICU. And then the second reason we study is because they are going to develop end-stage renal disease. So it's a very bad disease. Bad situation with multiple disease causing the obstruction. Speaking about prenatal diagnosis, very quickly, Louise present that. Usually we make the diagnosis in the second trimester by distended bladder, thick bladder wall, and keyhole sign, and bilateral hydronephrosis. But we can see this problem even during the first trimester, ultrasound, which we call megacysts. I use the terminology for LUTO for all of them, but megacyst I call the bladder distended. So I still using that terminology. But the most important thing is that I think if we can take something from here, to our home is that some taking home that we can do here is that we cannot diagnose the cause of the problem. So we cannot say that this is a posterior urethral valve, or this is a urethral atresia, or this is urethral stenosis, just based on ultrasound or MRI. Even if we have the best radiologist, the best sonographer, we will not be able. Why? Because all this disease can have the same features. The only tool that we may have the opportunity to diagnose correctly the cause is fetal cystoscopy, and we are going to talk about that. That we can try to do the same at the same time fetal cystoscopy, and we can try to do the treatment for diagnosis. We can try at the same time fetal cystoscopy for diagnosis and specific treatment. But after we do we make the diagnosis of standard bladder, possible LUTO, the first step is to see if this we don't have an associated anomaly. Because if we have, as she presented, or either chromosome abnormality or cardiac abnormality or other structural anomaly, then of course the prognosis will be poor. So first, we need to have a complete anatomy scan of this fetus. Sometimes if we have just good gestation aid, we can have also the MRI. We need to have a CVS or amniocentesis to rule out genetic or chromosomal disease, so genetic counseling is important. And then we need to see, we also a fetal echocardiogram, I recommend to exclude or rule out cardiac congenital heart anomalies. And then once we exclude all those associated anomalies, we are dealing with probably something that we call isolated LUTO. And how can we prognosticate those the disease? Based on two findings, two strategies. First is to use ultrasound findings, and I use the same thing that I use postnatally usually to evaluate the cortex or the renal cortex. But also the amount of fluid is very important. If we have oligohydramnios or severe or anhydramnios before 24 weeks, then the chance of have severe pulmonary hypoplasia and high mortality, death is very high. And the second step is to see the kidneys. So we evaluate the hyperechoic. If the kids are hyperechoic, we evaluate the cerebral hydronephrosis. I use the same strategy that the radiologists use postnatally. But so far, some studies they have shown that if we use the cerebral hydronephrosis, it seems that the cerebral hydronephrosis is not associated with prognosis. But the renal cortex cyst, the presence of renal cortex cyst, and also, of course, renal dysplasia is very well associated with prognosis. And something that we do also is that we do ultrasound guided vasculocentesis to evaluate the fetal renal biochemistry, but also we evaluate the bladder refilling after the vasculocentesis in 48 hours. And if it refills more than 45%, that shows that the kidneys are still producing urine. Then we use the fetal urinary biochemistry to evaluate if the kidneys are producing good or bad urine. And we can discuss afterwards how we do that. So then we have different stages. So the first stage is when we see, for example, at 20 weeks, we isolated LUTO, standard bladder with normal fluid, normal amniotic fluid. So probably we have a partial obstruction. And then if you see the kidneys, they are dilated, hydronephrosis, and they may have some hyperechoic cortex, but no evidence of renal dysplasia or renal cysts. And if you do the vasculocentesis, the biochemistry will be favorable. In this situation, we have good prognosis because we will not have pulmonary hypoplasia, so there's no need for intervention. Then if the situation progresses to stage 2, when we have already oligohydramnios or anhydramnios, and then the kidneys are dilated, but no evidence of renal dysplasia or cysts, but we can have hyperechoic kidneys. And if you do the biochemistry is still favorable. This is the perfect situation that we can treat those babies, because we can prevent severe pulmonary hypoplasia, and we also can try to prevent end-stage renal disease or renal impairment. And then we have a stage 3, that we have anhydramnios or oligohydramnios. We have already hyperechoic kidneys, and we have some cortical cysts, but no signs or no evidence of renal dysplasia. And if you do a biochemistry, they are not going to be favorable. That shows that the kidneys are still producing some urine, but are not, the urine is not in a good quality. So the kidneys are not producing good quality of urine. So then the question here, the question that we have is that if we should offer an intervention to prevent severe pulmonary hypoplasia, a perinatal death, and then to create a bridge to dialysis and transplant. And then later we found out that there's another stage of the disease in utero that's already an end-stage renal disease in utero, or intrauterine fetal renal failure, that we have ultrasound signs of renal dysplasia. We have mildly dilated bladder with thick wall. If you see the history of this fetus, you're going to say that before there was normal fluid, the bladder was extended. But if you see now, the bladder may be very, very small. So this case, this situation, usually we confuse them with polycystic renal, polycystic kidneys. That's a different disease. And then if you see, there's a progressively decreasing amount of amniotic fluid if you see the progression of the disease. So this situation is very bad because it has a very poor prognosis. It's associated with neonatal death right after the birth, or for severe pulmonary hypoplasia, because of severe pulmonary hypoplasia, or within 1 week, the progression to end-stage renal disease, dialysis, and transplant. Very severe disease. And this is an image of typical ultrasound findings suggestive of renal dysplasia, which is an anatomic finding. And then when you can see here, a mildly distended bladder that was distended before. Sometimes the bladder is even collapsed. But if you see carefully, you will see that there is a bladder there with thick wall. And sometimes you can still see the dilated urethral, posterior. So that we believe that is a progression of the disease. But of course, sometimes we can have already stage 3 very early in pregnancy, and sometimes we can have a progression of the disease slowly. So speaking about fetal therapy, we have different types of fetal therapies, and I'm going to discuss today about 2 of them. One is vesical amniotic shunting, which is considered a standard of care, and fetal cystoscopy, which is still under investigation, is still an experimental disease procedure. So, vesical amniotic shunt, we need to perform amnion infusion before we place the shunt, and the objective of the shunt is to bypass obstruction. And then, and the cystoscopy, the objective is to introduce a tiny telescope inside the bladder, identify the cause of the obstruction, and treat it specifically the cause of the obstruction. So of course, the ideal indication would be for severe LUTO with normal fetal renal function, but we can offer for different stages as we are going to discuss. But the main objective for the fetal therapy for LUTO is, main objectives are to prevent severe pulmonary hypoplasia and death, and also, if we can, prevent end-stage renal disease and improve the quality of life for those babies. So before we talk about specifically, we need to provide some evidence. And this is the Pluto trial, which is one of I think the only one randomized control trial that we have about fetal intervention for LUTO. And this is a very well written study that I recommend everybody to read, because this shows mainly the difficulty of performing a randomized control trial for rare disease like LUTO. And this study was stopped earlier because of difficulties in selecting patients and also in allocating patients to specific group. As you can see here, for example, some patients were allocated to receive percutaneous vesical amniotic shunting, but unfortunately, some of them decided to have just conservative management. And some patients were allocated to receive conservative prenatal management, and they afterwards decided for either termination of pregnancy or received a shunt. So this study, again, is very important because it's an exercise of how to review and how to do randomized control trial. And the best way to evaluate and analyze a randomized control trial, of course, is the intention to treat analysis, which in this situation didn't prove any benefit. But again, as I shown in the previous slide, this study had a very difficult situation because of selection of the cases and also because of the patients crossed from different arms. So this is a good example of study that sometimes we need also to evaluate as treated analysis. And if you see, the LUTO trial showed benefit from the shunt if we consider as treated analysis, with a survival rate of the risk relative was 4.3, which was significant, with 50% of 53% of them survived after shunt, compared to compared to very minimal survivals. But this study was not good enough, was not big enough. The sample size was not good enough to evaluate the impact of the shunting to the renal function for those babies. Let's discuss about fetal cystoscopy as a diagnostic tool. So those are the images that we can see. So from 16 weeks to 26 weeks, we can introduce a tiny telescope inside the bladder of the fetus, advance the telescope toward the dilated posterior urethra, and then we can see different images. We can see different diseases. If we see a membrane or we see a valve situation, then we have posterior urethral valves. And in this situation, we can use the laser fiber to open and to fulgurate the valve, and then we release the obstruction. But we have, as Dr. Wilkins-Haug mentioned before, we can have urethral atresia, that the urethra stops, interrupts suddenly, so we don't have the continuity of the urethra. And we have urethral atresia, that's a very severe disease. And we have urethral stenosis, that there is no obstruction, but the urethra is just a little bit narrowed or thinner. And then in this situation, urethral stenosis, maybe we can just put a tiny catheter through the urethral penis, perineal urethra, and then we can make it patent. Urethral atresia is more complex, and then we need to discuss, and I'm going to discuss shortly with you. So how do we do this procedure of fetal cystoscopy nowadays? So we perform a local maternal skin anesthesia, and then we introduce a tiny needle, and then we do intramuscular injection in the fetus to avoid movement and pain. And then we introduce a tiny telescope inside the bladder of the fetus, and then we advance the telescope towards the valves. And once we identify the valves, then we use the laser. We advance the laser, and we fulgurate the valves. And then the bladder will collapse because it will have the spontaneous drainage of we will have a drainage for the bladder after we fulgurate the valves. Speaking about the first trimester, the example that Dr. Wilkins-Haug mentioned, this is very interesting. So we did a study some years ago, and we found very interesting results. First, we had a megacyst from 11 to 14 weeks. So then we did a CVS. So I recommend to do a CVS if the bladder is very distended, because then you can have the results already at 16 weeks. And then 16 weeks, we brought those patients back, and we did a complete anatomy scan. Of course, 16 weeks has some limitations. We did a fetal echocardiogram, and we had already the CVS, the chromosomes, the genetic results. If we have the presence of associated anomalies, which she mentioned already is 30–40%, then the prognosis is very poor. But in the absence of associated anomalies, then we did cystoscopies. And what we observed is that we had about 60% posterior urethral valves, then we did the laser fulguration, but we have almost 30–35% urethral atresias. That was very complex and very severe. And then what we are finding now, and we found at that time, is that we are dealing with more complex situations. One of them is a megabladder, microcolon, intestinal hyperstalsis syndrome, that we have very complex bowel bad development of the colon of the fetus, and then we'll have problems. So in this situation nowadays, that was LUTO disease before, nowadays we are treating the bladder, we are preventing the lung pulmonary hypoplasia, so we are improving the survival, and we are preventing also end-stage renal disease. But we are dealing now, and then some of those babies, they have normal neurological development, but some of those babies, they have very bad bowel development, and they will need colostomies, and they will need also sometimes even a bowel transplant. So we are saving some more babies, but we are dealing with more complex situations. We also perform a multi-center study with 111 fetuses and with France and also Barcelona, and we observe this, and we compare fetal cystoscopy, vascular shunt, and also no fetal intervention. This was a retrospective study with some bias, of course. We expected the no fetal intervention group was the less severe forms, but very interesting, we confirm that the survival rate was mildly higher if you consider cystoscopy intervention. So even though we have bias, the survival rate was significantly higher in the cystoscopy and shunting group. But the most important find that we observed here is that cystoscopy, in the cystoscopy group, we had better renal function for those babies, 75% against 60% with a vascular shunt and 40% without treatment. And then we did a second analysis to understand that. And the second analysis was exactly what Dr. Wilkins-Haug was mentioning, that the cause of the obstruction is a very important prognostic factor. So if you see the posterior valves, for example, and we compare cystoscopy, vascular shunt, and no treatment, the patients that received cystoscopy and treatment prenatally had better outcome. On the other hand, those patients that had urethral effusion, we treated by cystoscopy or vascular shunt or no treatment, the outcome was poor, dependent from the treatment. And then we have also urethral reflux that we didn't treat for cystoscopy, but then the prognosis was good, independent if we don't offer the intervention. So no intervention was needed. So that shows that cystoscopy was important to select better the candidates for fetal intervention. And then we did a long-term outcome study, and our first question was, okay, how good was fetal cystoscopy to correctly diagnose the cause of the obstruction? And then evaluating 35 patients, including, again, France. This study was on France, Mexico, and Brazil. And then we observed 90% of accuracy. Then the second question, okay, let's evaluate patients that was we diagnosed with posterior valves and had received laser treatment. So the first finding is that there is a recurrence, which happens in about 20% of the cases. And if you have a recurrence, we did sometimes repeated fetal cystoscopy that was very highly associated with the fistula. So we don't recommend anymore to repeat fetal cystoscopy if there is a recurrence of a LUTO. But the survival rate in 2 years was, in 1 year was 56%, in 2 years 54%, very similar to the Pluto trial. But the normal renal function, which I'm calling normal renal function, no need for dialysis and transplant, in 1 year, 2 years, what about 75%, showing again that if we have posterior valves, if we select correctly the case, and then we do the treatment with laser, then we will have good outcomes. And then what about if we do shunts, no cystoscopies? So we also follow some patients, many patients at Texas Children's Hospital in Houston, and we, from 2012 and 2014, and we were placing shunts for stage 2 LUTOs only. And then we were following those patients weekly. So once the shunt migrated and got blockage, then we replaced the shunt. And we observed that the shunt got migrated blockage in about 57% of the time. And we repeat the procedures 2 to 5 times per case. But then if we did that, we selected well the candidates, and then also we follow weekly and we place the shunt as soon as possible, we have a survival rate of 85%. 86%, with normal renal function of 71%, similar than fetal cystoscopy. Again, that shows that the importance of selecting correct candidates for intervention, and also the importance of following those patients after initial treatment. We have pros and cons for vascular shunts and fetal cystoscopy. Vascular shunt, for example, seems to be easier, less invasive, but need amnio infusion. Sometimes the shunting is easier than just doing the amnio infusion. So, and then we have some shunt migration, we have shunt obstruction, and we have the risk of P-prone prematurity. Fetal cystoscopy The advantage that we can diagnose the cause of the disease or the obstruction, and we can treat specifically the cause of the obstruction. But then we don't need to do amnifusion. It seems to be more physiological for the bladder, the compression, which we are not discussing here, the bladder function after treatment. And then it seems to be more associated with normal renal function because we select more better candidates for this treatment. But it's more invasive. It increases the risk of pre-prom, and it has also preterm prematurity. And the most important is that we have technical challenges. Especially sometimes we can see urological fistulas. So we have two approaches. We can offer primarily vesicombination shunting, and postnatally we do a cystoscopy and we treat the cause of the obstruction, or we can do prenatally. We can do fetal cystoscopy, identify the cause. If it's a posterior valves, we can fulgurate the valves. If it has urethral stenosis, we can put a urethral catheter. And if it's a urethral atresia, we stop. We don't do the laser because we are going to cause fistula. And we just discuss with the patient. This is a very severe situation. Either we can discuss about termination of pregnancy, but also we can discuss about vesicombination shunting. And of course, if you have failure of the laser of urethral stenosis catheterization, then we can discuss about vesicombination shunting. But also the staging system is very important, because if I stage 1 LUTO, we have good prognosis, no risk of pulmonary hypoplasia. So those babies will survive without treatment. And then the management should be weekly ultrasounds. But if it progresses to stage 2, that we still have production of kidneys, of urine by the kidneys, but the urine is still in a good quality, then we can offer fetal cystoscopy or amniotic shunting. Stage 3, we have already production. We have a production of urine, but with bad quality. So the kidneys are not producing good quality of urine. Then maybe place some vesicombination shunting and try to pass the phase of lung development. And then if we need some amnifusions, but then is the real objective here is to prevent pulmonary hypoplasia, severe pulmonary hypoplasia. And then these babies may need dialysis and transplant. And finally, we have stage 4, that's already in intrauterine renal failure or end-stage renal disease in utero. We have extremely poor prognosis. And what we're investigating now is a serial amnifusions that we call the RAFT trial, to see if we can improve the lung condition, prevent severe pulmonary hypoplasia, prevent neonatal death. And then as a bridge to dialysis, we can allow those babies to get dialysis and transplantation. So I would like to present this single patient that was born with this huge belly that many people would say, this is a pruny belly syndrome. But at 17 weeks, we saw this fetus with huge bladder, compressing the spine, compressing the heart and the lungs. The heart was having bradycardia, and then urgently we did a cystoscopy, and we identified, we suspect of urethral atresia, and then we placed a shunt. This patient received 3 shunts because of migration of the shunts, and was born at 34 weeks. And this kid now is 8 years old. Postnatally, we confirm urethral atresia. This boy has normal neurodevelopment, normal lung development, and normal kidney or renal development, no renal failure. But this kid had vesicostomy for 7 years, and just this year he was treated and the urethra was reconstructed. So in conclusion, I believe that's very important to have a multidisciplinary prenatal approach with MFMs, obstetricians, radiologists, genetic counselors, geneticists, urologists, nephrologists, neonatologists, etc. And we evaluate the patient together when we provide a unique information and impression to the patient. It's very important also to have a prenatal staging system to define which stage of the disease regarding the severity of the disease we are discussing and how we are going to manage this baby. And then we are going to offer prenatal intervention depending on upon the prenatal staging system. And very important that once we diagnose LUTO, we need to see the entire picture. We need to see the entire baby, and the treatment just starts prenatally with our evaluation. But that means that this baby will need to have postnatally, a multidisciplinary follow-up and evaluations to treat that situation. So thank you again, and thank you for inviting me for this talk.
Thank you for a great talk, both really, really good talks. We have time for just a few questions. And Louise, I wanted to ask you the first question. If you could comment on the genetic testing scheme in terms of finding a LUTO in the first trimester. Mm-hmm. You mentioned in your very interesting case that you did Beckwith-Wiedemann studies, and also I was wondering if you could comment on the role of exome and genome sequencing in these cases.
Yeah, no, great. Thank you for that question, because I think for my interest, I think that's where things are going as well, is to try to further refine what the underlying cause is, and then allow the treatments to be much more directed to what the cause is. So certainly, there are associations with the overgrowth syndromes. I think one has to keep in mind that for Beckwith-Wiedemann, one needs to order specific type of testing. But then I think that we are moving very quickly to, as you know, at least the clinical exome for these prenatal cases. I think that would be helpful in identifying some of these rare conditions that can be associated with these large, really atonic bladders that can be often connective tissue disease as well. So I think doing some type of clinical exome, but I think more than that is probably the realm also of, we don't know, so it's associated with 22q deletion syndrome. Who would have thought megacystis is going to be 22q? I think we need to expand our testing so that we do get a better handle on what type of testing to offer. And then do we move from a clinical exome to more of a prenatal exome, which may involve more variants of unknown significance, but also provide potentially more information going forward.
Thank you. And then Dr. Ruano, you talked about the limitations of the Pluto trial, and many of us don't have access to fetal cystoscopy, and I was wondering whether when should we be referring these patients to someone like you at a fetal center with the ability to do fetal cystoscopy? It seemed like that may be where we're headed rather than placing these shunts ourselves.
Yes, Nita, this is a very good question. I'm going to give an example. Yesterday, I treated a patient 28 weeks, the multiple treatments. Okay, so this patient came at 17 weeks with bladder, standard bladder, and normal fluid. It was seen first. And then there was a vesicle, very well done, anatomy scan, vesicocentesis, and then amniocentesis, so excluded all other anomalies, normal chromosomes, normal karyotype. But the fluid was normal 17 weeks, and the bladder after the vesicocentesis collapsed, causing ascites. Then, because of normal amniotic fluid, the patient was referred to us 24 weeks to see, and then because the fluid was coming down, and then the bladder was already collapsed, and there was no way to put shunt or cystoscopy, but there was dilated hydrourethras with hydronephrosis, huge hydronephrosis. So then we need to treat the hydronephrosis. So answer your question is that it's very important once we find one of those cases, to refer as soon as possible to a center. Okay, why? Because there's a lot of things to be done, many things. First, we need to confirm the diagnosis, which is the simplest thing. Second, we need to rule out some other problems, as Dr. Wilkins-Haug mentioned very well. Third, we need to classify where we are at with this baby. For example, as I mentioned, before 18 weeks, we are dealing with more complex, based on the literature, based on my experience, we're dealing with more complex diseases. So I treat them. I don't wait, because also before 18 weeks, the placenta may produce some fluid. So the amniotic fluid may be normal, and we are dealing with a very complex disease. And so after 18 weeks, I follow the fluid, but also the renal cortex. If I see some hypercoid kidneys and some starting cysts, and then I do the bladder tap, and then maybe we do the vesical shunt. Doing cystoscopy or shunt is a matter to discuss. I should do lots of shunts. I do cystoscopy for some very, very specific patients that really classify or qualify for the situation. So the decision of doing shunt or cystoscopy, I think, is a very complex decision. I think the most important is to refer those patients as soon as possible to a center that can do a multidisciplinary approach, can rule out all the complex disease that may happen or the associated disease, and then we can focus with the patient on which way the patient wants to be treated.
Definitely. Thank you so much.
So I'll actually ask, though, as well. I think that there are a few centers, and I think one thing I've learned from the cardiac procedures is that none of them are the same. They're all different, and so it really is true that you have to have kind of a team approach addressing each one. So since there are not a lot of centers, are centers such as yourselves doing anything virtually to be able to screen the patients before they make a trip?
Oh, Dr. Ruano, you're on mute.
Yes, and come back to that case. If I could have treated a patient at 17 weeks that I presented here, I would have. Many of our colleagues would say, no, this baby is fine. But you see, we would have avoided the complication that we are seeing. So this is a very difficult, LUTO for me is a very complex situation. We are learning every day, but we need to investigate at that time, trying to extract as much information as we can to see if we can treat. I consider LUTO as an urgent situation. So that's why it's the only disease, for example, that I use fish sometimes to treat, and waiting for the final chromosomes or microarray. And I agree with you, Louise, that we are moving towards a more detailed evaluation, but so far we are using microarrays to guide our treatment. So thank you.
And it may be that it helps identify that the overgrowth syndromes do usually have posterior urethral valve. So it's not that we're going to direct them away from treatment, but direct them to a better treatment.
Exactly.
Well, this concludes the second session of the third session of the ISPD Virtual Education Series. And I want to thank everyone for joining us today. A special thank you to our wonderful speakers, Dr. Ruano and Dr. Wilkins-Haug. The presentation was recorded and will be available on the ISPD website within 1 week. And certificates of attendance for today's presentation will be sent out by ISPD within 15 business days. The next series will be on Wednesday, October 13th at 11 a.m. U.S. Eastern Daylight Time. Please visit the ISPD website for a link to register for that, which will be another great series. And thank you, and have a good day or evening, depending on where you're located. Thank you, everyone.
Great. Thank you very much.
Thanks.
Pleasure.